You may start your session now, Dr. Prashant.
Good afternoon, doctors. Welcome on this webinar on the role of Oseltamivir in flu management, brought by Hetero. Hetero Healthcare, as we know, is an innovative pharmaceutical company. Our journey began in 1993. We have 30 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 countries, 21,000 employees globally, and we have amongst the largest manufacturers of ARVs, APIs, and FDFs in the world. Hetero Healthcare is Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Fluvir, Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar for role of Oseltamivir in flu management, we have got speakers Dr. Pramod Jog, Dr. Mukesh Sanklecha, Dr. Prakash Vaidya, very senior speakers whose opinion will matter. They are with us. Welcome all the doctors, and I'll briefly introduce each one of you. Dr. Pramod Jog is a professor of pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 19, Chairman Mini Respiratory Module IIP, and author of the book Cophology. Dr. Prakash Vaidya, MD DCH Diploma in Pediatric Sleep Medicine, GCI, University of Colorado, with attached to Fortis Hospital, Mumbai, and Child Health Clinic, Mumbai. Senior pediatrician with special interest in pediatric pulmonology. Sir is Joint National Convener, Asthma Training Module, Revision 21-22, Co-Convener and Writing Committee member of Under 5 Wizards Module of IIP, Writing Committee member of Writing Antimicrobials Responsibly Module of IIP, National Trainer for IIP and TB Module, NRC Cup Module, etc. Sir has many presentations as faculty at IIP and other platforms. Welcome, Dr. Prakash Vaidya. The next speaker is Dr. Mukesh Sanklecha, consultant pediatrician with Bombay Hospital and Institute of Medical Science, Mumbai, Saifi Hospital, Mumbai, and has been in practice for past 30 years. Passions, pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching. Sir has more than 45 publications as index Indian and international journals and has been faculty in large number of national and international conferences. Welcome, Dr. Mukesh. Welcome all of you, and I hand over the session to Dr. Pramod Jog to take it forward. Thank you, all of you.
Thank you. Okay.
Sir, Mr. Sharing Thambolila, we can share.
Yeah, sure. I will start sharing in a minute. Yeah, I hope.
Yes.
Just tell me 1 minute. Share.
Hello. Yeah.
Just 1 minute. Just tell me whether you are able to see. Yeah. Can you see?
Now it is seen.
Very good. Thank you. 1 minute. Very good. So, thank you, Hetero Health Care, for this particular invitation to 3 of us. The topic is use of Oseltamivir in flu management. We are going to discuss about flu and the complications and the role of Oseltamivir and so many things in today's discussion. And it is a program by Hetero, but it is a heterogeneous program because my co-panelists, Dr. Prakash Vaidya and Dr. Mukesh Sanklecha, they are not only practicing pediatricians, but they are intelligent, genius pediatricians. So it's a heterogeneous program. And the moderator is the IIP president strain of 2016, just as we have different strains of flu every year. And my name is written in the style of the flu virus, which indicates usually the place of origin, the month and the year of isolation, and so on and so forth. So everyone can try this way. And when I went to the OPD today, of course, today the OPD was very light. For the last few days, I was very happy that the OPD is increasing and the monsoon is, taking up. But then one small little girl came with a doll in the hand. And while I was examining this particular small girl, she was telling her mother, don't worry, viral hai, it's viral. So even a small child knows that, doctor is going to say that it's viral and don't worry and all. But now the situation has changed. When somebody says viral, we many times, get panicky because we have witnessed COVID-19, we have witnessed H1N1, we are witnessing so many viruses which are taking a different turn. So when we say it's viral, we have to be very, very careful. And there are very few viruses which have some antiviral agents like Oseltamivir for flu, we have acyclovir for herpes, and so on and so forth. Okay. So in the beginning, for say 5 to 10 minutes, I will give some brief outline about flu and Oseltamivir, and then we will go ahead with discussion of the cases. So we all know that influenza-like illnesses are very common, though the father of all these influenza-like illnesses is influenza A and B. And one must remember that whenever a child is brought, fever, headache, particularly pain in the muscles, and many times, the parents are lifting even an older child and bringing the child to the OPD. I always suspect influenza. We have gone through the pandemic of H1N1. And if you take the overview of influenza in India, the cases of influenza and the deaths due to influenza have been on the rise for so many years. And if you look at the KYC, now this KYC is the know your customer. We are all used to this term. So this naughty influenza virus also has its own KYC. Why I call it naughty? Because it's an RNA virus. And all the RNA viruses have a peculiarity that they change their nature every year. And that influenza A causes frequent epidemics due to the minor antigenic variations. Okay. And these periodic pandemics, just as the ones which we discussed just now about the 2009, there have been 4 pandemics till now. One was in the beginning 1919, then 1957, then 1968, and at 2009 at different places, and the origin was different. So influenza A usually shows major antigenic variations intermittently, but otherwise every year it also shows little bit of change. And we all know the terms drift and the shift. Drift is a minor change, shift is a major change. Influenza B viruses, they infect only the human beings and they produce only local epidemics, but relatively they are stable. And influenza C virus infects humans and the swine. And influenza type C infections generally cause a mild respiratory illness, and they are not thought to cause the epidemics. Now, the 4 major global pandemics have created a terror in the mind. So whenever I say and tell the parents, that the child has flu, they don't get, much of worry in the mind. But when I say it is H1N1 likely to be, then they are, suddenly afraid. Uh, you know, and the transmission of the flu virus is basically by respiratory route, and it can spread to others up to about 6 feet. And the flu viruses are spread mainly by the droplets when people cough or sneeze or talk, and the droplets can land in the mouths or the noses of the people who are nearby, and they could be inhaled into the lungs. And we all know that there are different viruses, the influenza-like illnesses, H1N1, the severe acute respiratory illness, COVID-19, and everyone has its own features. And we will be going through some of them in the course of the discussion. And in children, we know that they have fast breathing or troubled breathing whenever they are in an emergency situation, sometimes with cyanosis, and the fluid intake is reduced. And many times, they are dull and sometimes they are irritable. We will also see some cases where we have some complicated cases of influenza. And I always put it as, 4 A's as complications of flu, where we have ARI, that is acute respiratory infection in the form of either pneumonia or ARDS, acute otitis media, absenteeism from the school and from the office, which affects the amdani, that is the income of the parents. and also antibiotic abuse, because one doesn't know whether he's dealing with viral or a bacterial infection. And that's why flu has to be diagnosed properly, though it's a difficult task. Okay. And the treatment typically involves categorization of this disease into A, B, and C. And the treatment is largely supportive. So if the case is mild, then the child could be given bed rest with increased fluid consumption, cough medications if required, antipyretics like paracetamol, and sometimes if there is a lot of myalgia, we may have to use anti-inflammatory agents. And usually children recover in 3 to 5 days, but the weakness may persist for weeks. And severe cases may require hospital admission and IV fluids. And the treatment typically involves antiviral agents, and there are two. The ones are neuraminidase inhibitors like oseltamivir and zanamivir. What they do is they block the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. And these drugs are active against influenza A and B. And there are others which are called as adamantanase M2 ion channel blockers. They interfere with the hydrogen ion channel activity of the virus, and they block the entry into the host cells. And they are active only against influenza A viruses. The names are amantadine and rimantadine. Now, going into the details of oseltamivir, it's a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And it's a prodrug which is converted to the active form oseltamivir carboxylate in the liver. And it inhibits the influenza virus replication and pathogenicity and prevents further spread of infection. And it is effective against all the strains of influenza A and B, including avian H5N1, swine origin H1N1, and H9N2 strains. This is the mechanism of action of oseltamivir. As you can see, the neuraminidase activity is depicted in this particular diagram, and you can see the red cross on the lower part of this particular diagram. So where the neuraminidase inhibitors, they will inhibit the virion release and halt the viral replication. And that is why even if you give this oseltamivir even little late in the course of the illness, ideally it is given in the first 48 hours and then it is highly effective. But then as it inhibits the viral replication, it can have its benefits even a little longer. And this was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries, and it has been approved by CDC and American Academy of Pediatrics. And all of our colleagues are aware of the dosage and recommendations. Adults typically receive 75 milligram capsule twice daily, and the treatment is for 5 days, and chemoprophylaxis is with the help of a single capsule of 75 milligrams once daily. This is for adults. And in children, the dosage depends on the weight band. So under the age of 15 kg, usually we prefer to give the syrup, which is about 2.5 ml, and that comes to about 30 milligrams, because the syrup contains 12 milligrams per ml. Between 15 and 23 kg, the dose comes to about 45 milligrams once daily for prophylaxis and twice daily for therapy. And then depending on the weight, we go from 2.5 ml to 6.25 ml. And children who are obese or have more weight, of course, they receive dosages like adults. Okay. There have been quite a few clinical trials related to the early use of oseltamivir and also empiric use. So it has been noticed that oseltamivir treatment reduces the lower respiratory tract complications, antibiotic use, and hospitalization, and reduces the severity of pneumonia. When you administer oseltamivir early, and both the probability of any severity of pneumonia and the probability of severe pneumonia, they increase gradually with the time from the symptom onset to the oseltamivir administration. But earlier initiation of oseltamivir after the symptom onset reduced the occurrence and the severity of pneumonia and shortened hospitalization due to the pandemic H1N1 2009. And there have been guidelines for the use. Particularly, WHO has said that empiric treatment is strongly recommended, and the treatment should be started as soon as possible. Laboratory confirmation of the influenza virus is not necessary for initiation of therapy. Negative laboratory test for H1N1 does not exclude the diagnosis in all the patients. And in high risk individuals who are exposed to influenza, one has to consider the resumptive therapy with oseltamivir. And early empiric supportive therapy and monitoring are important. And also, similar recommendations exist for the adults. Now, let us proceed to the discussion of some cases. And as we go along with the cases, we will have questions for our panelists for the day. So, the first case is a 3-year-old boy coming with fever, cough, cold, and progressive breathlessness over 3 days. The child is tachypneic. The saturation is 85% in room air. And you can see the blood gas report shows pH of 7, PO2 of 79, and PCO2 of 45. And this is the X-ray of the chest. And the child has been diagnosed to be a case of ARDS. He has been admitted to PICU. He has been ventilated. He received oseltamivir and supportive therapy. The counts are total count 4600 with polys 26, lymphos 70, and CRP of 5. H3N2 was positive from the throat swab, and the child was ventilated for 3 days, and then the child was all right. Now, after going through this particular case scenario, one always starts thinking whether early oseltamivir would have helped this child. A previously healthy child presented with cough, cold, fever, progressing over 3 days. Whether the treating clinician have prevented this progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront in the flu season. So these are some questions which come to our mind, and that's why I call it as a confusion. This is a confusion about certain things about flu, whether it is bacterial or viral, whether viral, which virus, like rhinovirus, adenovirus, influenza virus. If it's influenza, whether it is H1N1 or H3N2, and so on and so forth. And whether, as I said, whether we should start oseltamivir upfront, okay, and whether I should give it to every patient antiviral to play safe, okay. So, Dr. Vaidya, I will just like to have your opinion as to what is your impression about the incidence of viral infections, whether it has increased over a period, maybe particularly after COVID. So what is your personal impression about it?
Thank you, Pramod. I don't think incidence has increased. I think our sensitivity to recognize these as viral has increased. Because there was a time when people used to give antibiotics for every fever more than a day or two. And now we have realized that basically many of the infections are predominantly viral. And there are so many criteria which prove that. It can be multisystemic, it is milder. There is usually a interfebrile phase where the child is active, and there is no clear focus of infection. So once we get this kind of picture, it is viral, and we have recognized that, I think, more and more often. The incidence has always been high. It continues to be high. It is only that we are aware of this more today than in the past.
Sure. So basically, as you say rightly, we have witnessed waves of different viruses, because I remember when COVID was on the decline, slowly new viruses started coming. We witnessed, this hand, foot, mouth disease, RSV, so on and so forth. And even older children started getting affected. And the OPD many times, is now flooded by recurrent RTIs, otitis media, adenoidal hypertrophy, and we all witnessed the outbreak of adenovirus also. And I call that adenovirus has become a badenovirus, because the presentation of typical respiratory adenovirus had changed during last 1 or 2 years. And there are always diagnostic dilemmas related to the complete blood count, CRP, nasopharyngeal swabs, whether to do or no. And there are some therapeutic dilemmas also about antibiotic use, then the anti-flu medication, the metered dose inhalers, the intranasal steroids, and so on. Dr. Mukesh, what do you think? Generally, how soon the child is brought to a pediatrician for viral illnesses? What is your impression?
So I think the approach in parents varies based on their socioeconomic status. You would find an upper class mother will bring a child for a nasal block also to the pediatrician, whereas the lower class would bring it much later. But by and large, when should a child be brought to a pediatrician? So, if the child has extremely high fevers, looks sick, is breathing heavily, is not sleeping in the night, is not accepting feeds, the intake has gone down. So, these are so called red flag signs or danger signs which should alert a parent to bring the child to a pediatrician. Also, if, for example, fever is not coming down despite antipyretics, or the duration of symptoms has gone on beyond the customary 3 to 5 days. So, by and large, urine output has gone down. There are many episodes of diarrhea. So any alarming symptom that seems out of place from the so-called mild viral infection should encourage the parent to bring the child to the pediatrician. Why they eventually come is a different question altogether. But these are indications when the child should be brought.
Sure, sure. That's a great answer. So let us start with one case. Viru, is having fever for 3 days with cold cough. He has been on metered dose inhaler since 4 months. He is well controlled. He has received symptomatic treatment. He comes back after 3 days. And he is afebrile for a day, and the fever has come up again. Okay, initially he had fever for 3 days. He was treated, and again he has come up, but he has been active in between. The pediatrician feels that this is a case of recurrent viral upper respiratory infection, which, as I said, are now more frequent and occurring at a shorter interval. Many times the parents are worried and they approach. Dr. Prakash, what is your policy about giving antibiotics in such children?
So actually, I explain to the parents that this biphasic signature is actually the signature of a viral infection. You do not get a bacterial infection that behaves like this, where you have fever for 2, 3 days, a gap, and again fever. So this kind of biphasic picture, especially when the child is alert, active, interfebrile, fine, this is biphasic, and it strongly tells me that I do not need an antibiotic in this case. And also, it also tells me that this is not severe flu, because severe flu also you usually don't get this gap at all, and that's where you require an antiviral. But to answer your question, Pramod, no antibiotic here. By and large, we get away without using an antibiotic.
Right. And I am sure you will agree with me that the conviction of the pediatrician is more important than the parents, because many times pediatricians, they, feel that the parents might leave the pediatrician, go to some other pediatrician who might prescribe an antibiotic, and the patient will be lost for me. And, so many things go on in the mind which are unavoidable. But if the pediatrician is convinced at the back of his mind, then I think antibiotics can very well be avoided. This is very important, because in our day-to-day practice, we see hundreds of prescription of amoxicillin or amoxiclav being unnecessarily prescribed.
Cefixime
So,
too.
yeah. You want to add anything, Prakash?
Yeah, cefixime also is used too often on
Yes.
the empirical basis. So I think these we should, as you rightly said, it is the confidence that we have that goes on, that also encourages the parents to adhere to the prescription.
Right, right. And then Mukesh, how do you counsel such parents in addition to what Prakash just said?
I think that's a very sensible question, because the first step is to give the patients or the parents your time rather than your prescription. So time spent will ensure, number one, that they will not buy an over-the-counter antibiotic. Number two, they will not go to another pediatrician for an antibiotic. So if you talk to them, explain to them the natural course of a viral infection, about how a viral infection is usually self-limiting, about the risks of antibiotics, both in terms of side effects to the child, be it diarrhea, be it skin rash, be it vomiting, be it destruction of his gut microflora. So I think the trick is to spend time with the parents, talk to them, explain to them. At the same time, it is very critical that if the child comes very early in the infection on day 1 or 2, you may yourself be unsure whether it's a viral or bacterial. So to explain danger signs once again to the parent, to ensure that if God forbid this is a bacterial infection which actually needs an antibiotic, the parent is able to come back in 48 hours and tell you that either a new symptom has developed. For example, the irritable child has developed otorrhea, or the child has localized the lesion to the lung and you find crepitations. So as long as you can explain the danger signs to the parent and send him without antibiotic, but reassuring him that don't worry, in case the child does not improve, we will step in and start an antibiotic at the appropriate time. That will go a long way in reassuring parents and ensuring they don't misuse antibiotics.
Yeah, and now one question, Dr. Prakash. Many times, we are unable to rather identify whether this is a virus or whether it is a bacterium. Even within the viruses, sometimes it is difficult to identify the type of virus and also amongst the bacteria. So these are our enemies. So is it possible to identify these enemies clinically? Because, I had just jotted down some points and I'm sure you can always explain better about the clinical clues to diagnosis of viral infections.
Yeah, so right from in the beginning, I think one hallmark of a viral infection is multi-system involvement. So often when the child has cough, cold, as well as some loose motions, that is one of the strongest indications that this could be a viral. Apart from that, uh, as you said, it begins with a cold. Cold is hardly ever bacterial. And more importantly, the child is interfebrile active, mostly in a viral infection. Also, uh, cough and wheezing. Wheezing is never really seen much in bacterial. It is predominantly a viral picture. Now, today, we are actually having difficulty in distinguishing two different viral infections, both of which are potentially serious. One is flu and the other is dengue. A lot of dengue is also going on. And dengue can also present with high-grade fever, headache, cough, myalgia, exhaustion. So there is sometimes we need to do tests to distinguish between the two. But by and large, the signature of a viral infection is really obvious. It is usually multisystem, interfebrile fine, multisystem involvement starting with a cold cough. Sometimes there is wheezing. And of course, there is no clear focus of infection like you see in a bacterial. Like, for example, a follicular tonsillitis or an otitis media or something to do or a pneumonia. These focuses are not there. So that tells you that this is viral. And then your next point is which virus. So that's where sometimes investigations are required.
And as we all know, adenovirus can have involvement of other systems like mesenteric lymphadenitis or hemorrhagic cystitis. Bronchiolitis may come under the age of 1 year with RSV, and COVID-19 we had witnessed with fever, dry cough, and the loss of the sense of smell and all. And then Mukesh, just as Prakash explained about the viruses. Can you give us some clues for the diagnosis of bacterial respiratory infections? Maybe in brief, because we are dealing with flu more, but then just to complete the discussion.
Yeah, so as Prakash rightly mentioned, that if there is a single organ involvement, the likelihood of it being bacterial is much more. As you rightly put down, if you have a child with fever, high fever, and severe throat pain, no rhinitis, no cough, then this is more likely to be acute pharyngitis or acute tonsillitis, which is bacterial. They so so with single organ involvement. For example, suppose it's a lower respiratory tract. Then if you find unilateral signs, you find a particular lobe involved. You take an X-ray, you find it's a lobar pneumonia. The likelihood of it being a bacterial is much higher, whether it's strep pyogenes, it's Haemophilus influenza, or it's strep pneumonia. If there is some other focus, suppose I have a child with pyoderma, a child with an abscess somewhere, a child having septic arthritis. So that tells us that, okay, there is a source from where this bug is starting. So if I have that kind of a focus and then the child develops a respiratory tract infection, then I can suspect that it may be a staph. Because very unlikely that two different diseases are progressing at the same time with different etiologies. Once you go above 5, as you rightly put down, you need to keep mycoplasma, which we used to call the talking and walking pneumonia, no longer so because we've had several cases of serious mycoplasma infections even in immune normal patients. So, but mycoplasma needs to be kept in mind and sometimes significantly underdiagnosed simply because we don't think of it. We think of viruses, we think of bacteria, but we need to keep atypical organisms, and the incidence of mycoplasma is pretty high when you have patients with a lower respiratory tract infection above 5 years. And the availability of certain tests which can diagnose both viruses and atypical organisms is of a great benefit, because that gives us a clue sometimes. And because if you test for just one virus, if you test for only influenza, you may get it, you may hit it, you may not hit it. The moment you test for multiple organisms, there is a chance, at least early on in the epidemic, that you may be able to identify what virus is or what atypical organism is currently commoner in that epidemic.
Sure, that's a great answer. I just wanted the inputs from both of you about flu. We always say that flu will begin with respiratory symptoms, and predominantly many of our colleagues have a notion that if cough and cold are present, you cannot have dengue fever. Okay, this is something which is quite a prevalent notion. On the same lines, there are experts who say that flu can not only come with respiratory infections, but also can come with diarrhea and abdominal symptoms. So what is your personal experience and what is your information about this?
Absolutely. Diarrhea is often present in children who have severe flu, and it's my personal experience. And previously, we used to say that dengue does not, at one time when dengue first came, it was thought that it does not involve the mucosa at all. And we don't get symptoms of catarrhal disease. But that is no longer true. We do see dengue with cough, with cold, with respiratory symptoms. So there is really a big overlap between flu and dengue in practice. And sometimes you really need to test out, at least look for a dengue negative before you're willing to say that this is flu, because to diagnose flu with a swab is a little expensive proposition and not easily available also.
Yeah, so
Sure.
I think
And Mukesh, what do you think?
when Pramod put this question and Prakash began off by saying that the moment there is multiple mucosal involvement, it's viral. So in that itself, the message is going through. It's not just influenza,
It can
but
be.
most viruses come as multi-system. We had adenovirus where sometimes there were no respiratory symptoms. We have influenza, so multiple mucosal involvement is the hallmark of a viral infection. So you cannot say if the child does not have cough and cold and has vomiting and loose motions, it's not likely to be adenovirus or influenza. So multiple mucosal involvement is viral. And whether it's influenza, whether it's adenovirus, most viruses affect multiple systems and will come with multisystemic presentations.
Sure, that's very good. So now this is a child, a 4-year-old child with cough and fever of high grade for the last 5 days, and he is not settling with oral medicine. Typical situation in the OPD. And on the admission itself, the child is tachypneic. The parents see that the abdomen is, just moving up and down, and this child needs oxygen support. And you can have a look at this X-ray also. The hemoglobin is 11, total count is 1620 and the platelet count is 132,000. SGPT is 381, SGUT is 168. And the nasopharyngeal aspirate, which was done, which was positive for H3N2. So this was a case of influenza with low WBC count and low platelet count. So I just wanted, Dr. Prakash, your opinion about how influenza affects the hematological parameters. Many of us feel that, lymphopenia, I remember in the 2009 pandemic, everybody said if it is, lymphocyte count, which is very low, 15 and 20, be sure that it's, H1N1. And so many discussions went on at that time. But now, at the moment, when you see the hematological profile or a CBC for that matter, in a child of this particular clinical presentation, what is your impression about this particular hematological parameter about CBC in a child with flu?
So when I would see this parameters, the first thing I will definitely want to rule out whether it is dengue, because there is hepatic enzymes are elevated, the platelets are low. Once I know that this is not dengue, I can definitely explain that flu can cause similar picture. Flu does not always behave like this, but flu can also cause a CRP which is not very low. So do not use high CRP to exclude flu. Second thing is that the count can be neutrophilic in the beginning, like in any other virus. But what picture that you have shown is a child with multi-organ involvement. There is hepatic involvement, there is a depression, there is a hematological depression. So this is a more severe kind of influenza. Possibly there will be renal involvement here, and this child may possibly head for a more for intensive care treatment because he has got multi-organ involvement. So this is one of the rarer manifestations, but this also is compatible with flu, and we should therefore be aware that it can come like this, and we should probably start antivirals in time in a child who is not doing well in the flu season. I think that is one take-home message that I have given myself.
Yeah, sure. That's great. And then, Mukesh, whether oseltamivir we should start empirically or after investigation, because maybe for in the same case, for example, before doing the nasopharyngeal aspirate or the swab, suppose if the child would have only come with this cough and high grade fever and not settling with oral medicines, and the parents probably do not afford this nasopharyngeal swab. So what is your take on this, whether it should be started empirically or after investigations?
Yeah, Dr. Zog, if you'll go back to the X-ray,
Yeah.
the X-ray slide. So now this child is obviously unwell and little more unwell than usual. And the X-ray is showing a right, probably lower lobe consolidation because it's not silhouetting the right border of the heart. And so this child will probably go into the ICU needing oxygen support. Here is a sick child. So our policy in medicine is always when you have a sick child, number one, you investigate more aggressively. And number two, you treat more aggressively to start off with. You may eventually pull out, but this kind of a sick child, I would probably give empiric antibiotics also because I would be concerned that this is a sick child and I don't have a etiological diagnosis yet. So definitely I would investigate this child more. I would ask for a blood culture. I would ask for viral studies. And I would, now this decision to start Oseltamivir and antibiotics, obviously child is sick. So this kind of a child, you would empirically start both. And my threshold will be much lower if it is the season of influenza. If in the past 1 week, 2 weeks, I've seen several children whose swab has come positive, who has had influenza, then I would not even blink an eyelid. Even before I started antibiotic, I would start oseltamivir. In direct contrast, if I've seen in the past 3 months, whatever serious children I have admitted, and their viral studies have not thrown up influenza a single case, then maybe I would wait and get my viral studies back and then start oseltamivir. But guidelines clearly mention that in the unwell child or in the child where the potential for serious influenza is very high, there is no reason to confirm the diagnosis of influenza before starting empiric oseltamivir.
That's a important point. Prakash, now going ahead on the same case, suppose Mukesh has started, say, some antibiotic along with oseltamivir, and the report has come as, say, H3N2 positive. Will you withhold antibiotics now, or you will continue both antibiotic as well as antiviral?
See,
Because
one of
on
the
one side we always say about this antibiotic stewardship and de-escalating those antibiotics and all, no? So how would you put it for the sake of
So
our
again, it really
pediatricians?
depends on the context.
Okay.
If the child is in the ward, the child is stable and not very sick, then surely I would be able to say that this is flu alone. But flu has a very high amount of secondary infection, especially with strep pneumonia. So if the child is in PICU, it's a sick child with multi-organ failure who has also come H1N1 positive, then I would probably not dare to stop the antibiotic because this is a sick child in the PICU, and we do know that there is a certain amount of colonization with bacteria, especially in children with influenza. So this is not the child where I would stop an antibiotic.
Sure, that's great because 25% of children with influenza, they do have secondary bacterial infections and pneumonias because of Streptococcus pneumoniae. And this is another child, a 3-year-old child with cough and fever for 5 days, and fever not settling down. The counts were normal, and nasopharyngeal aspirate showed H3N2. Even this year, H3N2 in Pune particularly is definitely getting isolated more than H1N1. Again, 5-year-old child with cough, cold, and fever with normal count, but CRP 38, nasopharyngeal aspirate showing H3N2, and you can see the X-ray of the chest here. Dr. Mukesh, what are the factors on which the clinical response to oseltamivir, depends? That means, the child is being given oseltamivir, and, are there any factors like related to the patient, on which the response would depend? That means, is it that it is flu, you give oseltamivir, and the child is definitely going to respond? Are there any other factors to the best of your knowledge?
Okay, so I think one of the most important factors is the timing of initiation of the drug. We all know that for best results, it has to be used within the first 48 hours. So be it varicella, where you must use acyclovir in the first 48 hours. So your timing is important. Obviously, your dose is important. The child has to retain the medication. Of course, the diagnosis has to be correct. It has to be influenza for oseltamivir to work. Now, so there are many drugs that are available for resistant uh, influenza, but they're not available in India. So the only drug we have for use in influenza is oseltamivir. So otherwise, if there is resistance, then the child may not respond, but that is beyond the realms of routine practice. There's no way we can check for drug resistance. Now, the other issue is, as Prakash rightly mentioned, the risk of superinfection with strep pneumonia, with Staph aureus, and strep pyogenes. So if I've started oseltamivir and the patient is not improving in 48 to 72 hours, or he improves and then worsens, or is very severe to start off with, that is the area where I can suspect a superadded bacterial infection. And in those patients, I would probably use an antibiotic. So initially severe disease or a disease which has not responded to oseltamivir for more than 48 to 72 hours, or initial improvement and then the child goes downhill again, then we wonder, is there a superadded bacterial infection? And then I would start antibiotics. So I think these are the factors that would influence a response to oseltamivir.
Sure. And then, Dr. Prakash, taking this question ahead, child, as we discussed in the initial part of the presentation, comes little late on day 5, 6, but he is H3N2 influenza positive. So, at this moment, what is your outlook? Will you still like to give oseltamivir, knowing that it works wonderfully in the first 48 hours only?
No,
So,
I would, yeah, that's a good question. It does not say that it works in the first 48 hours only. It says it works best in the first 48 hours. But any child who is sick and who has got a positive flu swab here, I would definitely give oseltamivir on any day of presentation, because this is what the guidelines encourage, that it is better late than never. It is not that you can't give because it's a time-bound drug. So definitely I would give it in a serious child, even if the child has come beyond the 48 hours to me.
I think Prakash has worded this reply very well. So he says that if at fifth or sixth day the child is improving, Prakash is not going to give it. He has very categorically said serious child. So if on the fifth day child is still really sick and in the ICU not improving, and his swab comes positive, he would give oseltamivir. At the same time, if it has run its course of illness
That's
and
true.
the child is clearly much better, there's no reason to give oseltamivir.
sure. And we have the evidence for this statement of Dr. Prakash, because in Pune also at Sassoon Hospital, there was a large study conducted where, children were given oseltamivir even when they came late, and they showed remarkable improvement in their, conditions. Okay. So now this child, again, as a surprise, came to us with, 4-year-old child with cough and cold for 5 days, high WBC count, huh? And high CRP of 136, so which we were not happy about. And he had continuous high fever and turned out to be adenovirus positive. So this is, something as a surprise we can get in a season of influenza. And now, Ria, by the way, the names of these children have been changed. And Viru was obviously viral, and Ria obviously had, onset with rhinitis, so it's Ria. So 5-year-old girl with high fever for 5 days and cough and cold for 5 days, and she was sick, but had mild wheeze, but no crepitations. Now, Dr. Prakash, will you give antibiotics to this child?
I would require more data on this. When you say high fever, is the child, so the child is has high fever, the child is sick looking, is the child interfebrile active? Uh, I think this is the child with, if the child is sick in high fever, we would definitely send cultures, we would send the investigations, but till the investigations came and till we knew, 100% I would cover with an antibiotic. Stewardship doesn't mean not giving antibiotic, it means giving it when it is required and giving it judiciously. So here I think I would definitely give, since it's
Right.
5 days of
So,
fever.
yeah. So this child was put on augmentin. WBC count was 2800. The neutrophils were 10, lymphos were 70, and the CRP was 34.7. The child was even put on oseltamivir, but the nasopharyngeal swab turned out to be positive for rhinovirus. So the question that many of our colleagues have as to what is the sensitivity of influenza PCR and the treatment decision. Many times we send the swab, but then it comes positive for rhinovirus. On one side, we have a strong suspicion that this is likely to be, flu. So, what is your take on this particular situation?
Uh, you want
Yeah, you can. Anyone, Prakash, you can
Yes,
say anything. Yeah.
rhinovirus, as we all know, is a very, it's a red flag. Rhinovirus often is a commensal and does many times, most of the PCRs will detect rhinovirus stroke enterovirus. So that does not mean anything that it is a causative organism. So I would not go by this swab at all. Now, your question was that whether the flu swab has a high sensitivity and specificity. I think a properly done nasopharyngeal swab, since it's a PCR test, definitely has both a high specificity and sensitivity. However, clinically, if you really feel that this is the flu season and you have started and the child is sick, then you will still, if you have started a oseltamivir, you will still continue. But in a non-sick child, you have just started oseltamivir and you have sent the swab also, and the swab comes negative, you are justified in not continuing oseltamivir there. So I think a lot depends on the context of the patient. There are no clear-cut hard and fast rules here.
Yeah, I think
Okay,
I agree
Mukesh.
with Prakash on this. Yeah.
Yeah.
So,
Okay.
first of all, you have to see as to how this influenza was diagnosed. Was it a multiplex PCR or was it an antigen detection? Because there are some tests which just detect antigen of influenza and they have high specificity but very poor sensitivity. So if it comes positive, then we are on secure ground, but it comes negative, it could still be influenza. So if you're doing a multiplex PCR, I go with what Prakash says, good specificity, good sensitivity. But if you're doing antigen, which is far cheaper, single test, may cost a few hundred rupees, and if you're doing that, and if it comes negative, you're nowhere still. If it comes positive,
Just out of
then
curiosity, are people doing antigen test in flu? I don't,
yeah,
I'm
yeah.
not
Some
sure.
some
Yeah.
some labs are still doing it. Yeah,
Okay.
but most are doing it now. The other issue is that how reliable is the PCR? You have several labs which run a set of 3 viruses, 5 viruses, and then you have the multiplex PCR which runs about 10, 12 viruses. So the PCR has to be done from a good lab, a standardized test. I have some panels which become only adeno, RSV, and influenza. So we need to see whether the panel that we are doing is a standardized panel. If you're using a multiplex PCR like BioFire, which we use in our hospital, it is standardized both internationally and in India. But there are some panels that a lot of labs offer, which I'm not so sure how reliable that set would be.
Okay. Okay. And this is another, 7-year-old girl and the daughter of IT sector parents. As you know, IT is not only information technology, but it is also inquisitive and troublesome sector of parents. So this girl has high fever for 3 days and the throat, complaints of throat irritation. And she has an examination 2 days later. These days, exams go on every 15 or 30 days. So the parents are always worried. And there is mild congestion in the throat. Parents already have given paracetamol, and flu and adenoviral infections are around, and the pediatrician is now worried as to what to do. On one side, these are the symptoms and these are the parents. So, Dr. Prakash, how would you manage this child, particularly in this setting? Yeah.
So you said there was throat irritation. I would first do a thorough clinical examination and see if it is bacterial. So is there any lymphadenopathy? Is there any halitosis? Is there follicular tonsillitis? Is there a patch on the tonsils? So that will tell me whether it is bacterial, though sometimes adeno can behave like this, and so can EB virus actually, where you can get all of these. So that is my first thing. If I did find follicles on the tonsils, if I did find lymphadenopathy, which was tender, some halitosis, maybe symptoms of adenoid enlargement like mouth breathing, I would definitely start an antibiotic here and then probably go for the test. Now, CBC CRP, yes, it is a test that is not always useful because CRP can be high even in adenovirus. So we cannot be sure that it is bacterial on that basis. A throat swab, if you are meaning that we do a nasopharyngeal swab for a PCR test, fine. But a throat swab for a gram stain or bacteria is not really going to be useful here. And empiric oseltamivir, this is not to me the picture of flu at all. With a child, I mean, this is not entirely the picture of flu. Yes, high fever is there, throat irritation is there, but there don't seem to be any, you have not mentioned whether there is any cough. You have not mentioned whether there is headache. These are and lethargy. To my mind, a child with severe flu after 2 or 3 days becomes lethargic, and that is actually my cue that this child probably is severe flu and requires oseltamivir. So here I am not very sure on this basis. If I did find that there was nothing in the throat, if the swab was not, if the no follicular tonsillitis, not much of lymphadenopathy, no halitosis, not like bacterial, then yes, in a flu season, I would definitely give empiric oseltamivir. But if, since they are IT sector parents, I would also send a flu swab. And if this flu swab came negative, I would then stop oseltamivir. And if it is positive, then I complete the full course.
Right. Very well said. So, Mukesh, generally, if someone starts oseltamivir, how long should this medicine be administered?
I think the guidelines are 5 days.
Right. Okay. That's great. Now, this is Tejas, 3-year-old boy with cough for a week and high fever for 3 days with crepitations. He was put on co-amoxicillin by one of pediatrician, and he was admitted for persistent fever. Now he was put on IV augmentin. The WBC count was 7,750. Neutrophils were 49. CRP was 2.8, and the swab showed influenza A positive. So oseltamivir was added. And the same question which I addressed to Dr. Prakash earlier, whether one should stop antibiotic at this juncture. So we have already answered it partly. Do you want to add anything, Prakash, to what you said earlier?
Here, I would stop antibiotic because to my mind, it was not required in the first place.
Okay.
This is not a child who is very sick. There is cough.
Correct.
Yeah. So, and we know the cause now. So I think here I would withdraw.
Okay, that's great. Mukesh, now that we have heard Prakash, would you prescribe antibiotics concurrently in your practice when a child comes with very high fever, flu season, and the child is really sick, one doesn't know what he's dealing with. So, because many of our colleagues, finally end up giving both. And then just, it is a topic for discussion. Of course, pediatricians will do what they want to do, but then at least they should know that what they are doing is right or what they are doing is wrong. So, what is your take on this?
So once again, the moment the severity of the illness is more, you are justified in investigating more aggressively and treating more aggressively. So the same child, if he's in the ICU, you'll obviously give him antivirals, antibiotics, maybe even staph coverage. In direct contrast, a stable patient in office practice who is willing to follow up, there is really no urgency of starting antibiotic. We know that we treat acute pharyngitis with the fear that group B streptococcal infection is the culprit and the risk of rheumatic fever and PSA-GN. But the window period you have is 9 to 10 days. You need to only start antibiotics before 9 days to prevent that outcome. So actually there is really no urgency to start antibiotics. Once again, you would ask this patient to follow up in 48 hours and see if he's actually worsening, not to give antibiotics in the first step.
Right, right. And then this particular child, again, the parents come and say that today morning, the younger one, who is 8 months old, has come with high fever since yesterday. This is the contact of this chap who was influenza A positive. and the younger sib has come with high fever since yesterday. So, Dr. Prakash, will you start prophylactic oseltamivir for this younger sib
So that's
being
curiously
in?
exact same situation I had today. I have a child admitted with a febrile seizure. They
Okay.
are twins. One twin admitted with a febrile seizure turned out to be influenza A, and 2 days later, the other child has also started running fever. The difference was that the other twin was active, playful, just a low-grade fever. So I am aware that this child has a high probability of influenza here. But then going by the guidelines, you are not going to give oseltamivir in mild influenza. I said we will wait and watch. If this child continues to get high grade fever and become sick, surely without a swab, I will start oseltamivir and complete the course. On the other hand, he recovers in 2 days' time, then I can get away without using oseltamivir here. So I think it depends on the situation really, but
Sure,
not
that's
prophylactic because the child is not immunocompromised.
right, right. That's very good. And this case, Dr. Prakash himself has shared. So I have put it in this presentation as an 11-year-old boy with fever, vomiting, cough, cold, altered sensorium for a day. And one thought whether it is encephalitis. And the X-ray chest done showed haziness on the right lung. The child was intubated in the emergency room and shifted to the PICU. LP was normal, CSF normal, and was started on antibiotics after sending the blood culture, IV antivirals, and other symptomatic management. And the report showed hemoglobin of 11, WBC count of 9,000, platelet count of 2 lakhs, and the other parameters. Here, the nasopharyngeal swab showed multiplex PCR detected influenza A H3, and the CSF meningitis panel was negative. And these were the X-rays of this particular child. You can have a look. The neurologist reviewed the child and opined as viral encephalitis, and he continued to have fever spikes. And on day 2 of the hospital stay, child had low urine output, had creatinine 2.24 and blood urea nitrogen 25. The pediatric nephrologist reviewed and opined as acute kidney injury and advised stoppage of IV acyclovir and to UHG abdomen plus pelvis, and that reported mild splenomegaly, both kidneys showing raised cortical echogenicity. EEG was reported as normal, and the MRI was also normal. And on day 4 of hospital stay, he was noted to have haziness in the right upper lobe and paracardiac shadows, suggestive of aspiration pneumonia, for which he was given prone ventilation, chest physiotherapy, and IV antibiotics. So, with this, Prakash, would you like to, speak more about this case, and what are your take-home messages from this case?
My message only is that flu can be more serious than just a respiratory infection. It can involve the CNS, it can cause acute kidney injury, it can cause multi-system failure. So one should be aware. And this has happened, this child, it happened without warning. This was not an immunocompromised child or a sick child. He was transferred from an outside hospital with a very short history of 2 or 3 days. So we should be aware. The only take-home message from this is that flu can be very severe, and we should be aware of this. And uh, I think once you suspect that this child with flu is deteriorating, you should have a low threshold to start oseltamivir, especially if it is the flu season. Of course, investigate, send tests, and monitor, but do not delay oseltamivir because flu has a potential high chance of morbidity and even sometimes mortality.
One quick comment, Pramod.
Yeah,
So,
yeah.
when it comes to acute influenza, encephalitis, or encephalopathy, this is probably encephalopathy since CSF was normal. They say that 10% of all hospitalized patients with influenza will have CNS involvement, and 25% of patients who are in the ICU with influenza will have CNS involvement. So, this is something that we may not consider if the patient comes with a predominantly neurological presentation. In addition, as Prakash rightly mentioned, almost 50% of influenza hospitalizations and deaths occur in the low risk group. Your high risk is who? Those below 2 years, those with a cardiac shunt, those with a primary or secondary immunodeficiency, those with asplenia, those with thalassemia, sickle cell anemia. So remember that influenza does affect the high risk much more. But 50% of hospitalization and 50% of influenza deaths occur in not high risk groups. So we need to relook at our approach to influenza and not just target high risk groups.
Very good. Another case which I witnessed last year, that was a 1-year-old child with fever, cough, cold, and came with status epilepticus. And the nasopharyngeal aspirate showed H3N2. The counts were normal. The MRI showed non-specific encephalitis changes. The CSF was normal, and it was diagnosed as influenza encephalitis. So the neurologic manifestations of influenza can be varied, as we saw simple febrile convulsion can occur, influenza-associated encephalopathy due to cytokine dysregulation, acute necrotizing encephalitis, which is also very well known, and the pediatric neurologists always discuss this in details in their conferences, Guillain-Barré syndrome, and aseptic meningitis. So these are the neurological features. Another case shared by Dr. Prakash is the 10-year-old boy who presented with stage 2 of fever with rigors, with headache, no clear focus, tonsillar crypts, total count of 13,000 with 84 polys and CRP 32, and influenza. This particular throat swab was positive for influenza. Now, Prakash, when you prescribe oseltamivir to children, how well is it tolerated, and whether there are any major adverse effects of oseltamivir that you have seen in your practice?
So in my experience, it is well tolerated by the majority. Some of the patients do have gastric irritation. Some will get worsening of the GERD, and sometimes we do need to give an antacid, or rarely even maybe a pantoprazole to counteract the side effect. But the majority tolerate it very well in my experience.
Okay, and Mukesh, what is your experience?
Yeah, I agree with him. The
Okay.
only thing is that if the child is on an antipyretic, on maybe a bronchodilator, maybe an antibiotic by some, that can mess up things. By itself, I think Oseltamivir, what Prakash says, well tolerated.
Okay. And then this is another case shared by Dr. Prakash, where he had influenza A, H3N2 with RSV together. And the child was treated with oseltamivir and also symptomatic management. And another child, again, influenza plus RSV. We discussed that co-infections with two viruses can occur. Just for the information of our listeners, any one of you, maybe Dr. Prakash, you can just tell the listeners as to which viruses isolated in the throat are definitely pathognomonic of the disease, because we have panorama of viruses like rhino and influenza, para,
So
RSV, adeno.
yeah. So the consensus here is that rhinovirus is often a bystander. When you look at viruses like influenza, RSV, adeno, metapneumo, if you identify any of those, and if the clinical context is fitting in, then this is a likely pathogen. So
Okay.
these two cases that I shared, both these cases had got signs of RSV, but very sick children also. And both had got, RSV like bilateral hyperinflation, wheezing. So luckily nowadays in our hospital, we get a flu swab, which also has an additional RSV pickup for a cost which is only marginally more. So I don't have to do that expensive multiplex PCR biofire. So many times we do pick up co-infection with these viruses. And I think here both are probably responsible. I would not say one is a common son.
Okay, wonderful. And then Mukesh, do you have any information about any contraindications or precautions before you start oseltamivir?
No, I don't think. I think this is an emergency medication,
Okay.
and in fact, it definitely indicated in the high risk infant who has a congenital heart, who has sickle cell, who has nephrotic syndrome. So by and large, I don't think there are any contraindications. Okay, you'll need to monitor for adverse effects, but by and large, no.
I'll just add to this that oseltamivir is an oral medication. It is not parenteral at all. So if there is ever a contraindication for oral medication, like say the child has got some big GI problem, hematemesis, or maybe paralytic ileus or some such problem, then yes, then we are handicapped by not having a parenteral medication. But as Mukesh said, there is hardly any contraindication except these very unusual ones.
Okay. And then one last case, maybe, a 10-year-old child with H3N2 influenza, high grade fever, and not associated with chills or rigors, and active in the interfebrile period, vomiting since 2 days, and cough for 2 days. and was treated with oseltamivir, paracetamol, and nebulization. And a case of influenza B along with RSV. So this was the child which Dr. Prakash had shared, was admitted with influenza A elsewhere and required HFNC support and treatment with antibiotics and oseltamivir and MDI for his underlying problem. And this was the X-ray of this child. So now, in general, question to both of you as to about the overall experience about oseltamivir. I am sure the experience has always been, quite favorable. So, do you have any important take-home message about what we have discussed? So we have just said that the proper diagnosis and early treatment can prevent the flu complications, and the empiric use of oseltamivir in serious cases or where they are indicated can reduce the complications, hospitalization, and antibiotic use. And many societies have recommended the empiric use of oseltamivir. As we discussed about complications, I thought it is worthwhile putting down some complications related to flu. As we discussed, otitis media, pneumonia, and usually Streptococcus pneumoniae or Staph aureus co-infection, and also exacerbation of chronic pulmonary conditions like asthma and respiratory failure has been reported in 5%, and acute laryngotracheal bronchitis. This was the child who had that respiratory complication. So I have just put it over here. He was put on high frequency. And then complications like toxic shock syndrome, cardiac complications of influenza like myocarditis and pericarditis, myositis. Many children who come with severe calf pain, which is supposed to be more with influenza B, and bilaterally in the gastrocnemius and soleus, and this is associated with rhabdomyolysis. Hepatic complications, everyone is aware about the Rye syndrome associated with influenza B, and when treated with salicylates. So influenza should never be treated with salicylates. And we all should know that flu vaccination is something which would be useful in great majority, though the efficacy is in the range of about 50 to 70%. I always say happy birthday to flu along with happy birthday to you, because every year annually one has to receive one shot, and let it be on the day of the happy birthday. So coming to the end of today's discussion, this is a virus which is fast and furious, okay, with abrupt onset, high transmissibility, rapid progression, going fast into ARDS and getting vertical discharge very fast in case if you do not suspect of you act lazy or careless. And oseltamivir has to be given quickly. So everything in influenza is very fast and furious. And we have gone through all these SMS precautions, all those 5 H's, which I always say, Hasta Pancha Sutri, related to the hand. That is hand wash, avoiding the handshake, using the handkerchief, keeping others at hand's distance, and avoiding hand touching, okay? And also saying goodbye to others by namaste and not shake hands, okay? So with that, I thank all the listeners. I thank Prakash and Mukesh for giving excellent answers. And I always say that it is important to prevent flu, diagnose flu on time and treat on time, because flu, FLU, it ends with U. And you are the ones who should have all the information related to influenza and the role of oseltamivir in the management of influenza. I thank Hetero Pharma again for giving us an opportunity to, give us give opinion or our information to all our colleagues. And as I said, it has become a heterogeneous program with 2 genius pediatricians, giving their inputs in a brilliant way. And I'm sure we have discussed nitty-gritties of this particular virus and the management aspects, particularly for the benefit of pediatricians. Thank you.
Thank you, sir.
Yeah.
Sir, one correction.
Thanks, Dr. Zog. Yeah, we
Thank you.
enjoyed your moderation.
Yes, yes.
Brilliantly
Sir,
done. And
there is one correction.
I think interaction with Prakash was very stimulating.
Yes, yes. Sir,
As
there's one
always.
correction. There are not 2 geniuses, there are 3 geniuses in this meeting.
Yeah, it's just
Pramod, we are
humility.
used to as a brilliant presenter. And he said it again.
Excellent, excellent. Sir, this, I mean, such a topic you
yeah.
made it so lively. Yes, it's lovely. And lovely insights, finally, that's what matters to our patients rather than those cases on case studies which are published internationally. I'm sure the audience must have benefited. Thanks, Dr. Zog. Thanks, Dr. Vaidya. Thanks, Dr. Saklecha. Thank you so much. It was a pleasure listening today. एक तास कसा गेला कळलं नाही बघा. Thank you so much.
Thank you. Thank you.
Thanks, Mark.
Thinking that initial two alphabets of Mukesh Sanklecha are MS, so he made it simple. MS is made it simple, and Prakash. He threw light on the topic, so that was Prakash. Okay, so that's okay.
Beautiful.
Thank you.
Thank you so much.
Thank you.
Thanks, marketing team,
Thank you.
thanks, IT, thanks, sales people. Wish you a wonderful evening, sir. Thank you. Take care. See you soon.
Okay.
Thank you.
Okay. Bye.
Yeah.
Bye.